let's move into the next slide, because I think that I think that sometimes there is an impression that we are somehow so focused on the therapy itself and some of the molecular diagnostic tools and so forth, that the actual care of the patient perhaps doesn't get as much play in not only in the conferences, but perhaps in what is being presented to clinicians who are trying to learn about AML, and also to patients. So I want to make sure that we hit all three of these bullets. And the first one is management and prophylaxis of infection. And Agnieszka already mentioned at the beginning of our discussion that there are actually new, or at least summary guidelines that are available on the topic specifically of antifungal prophylaxis. But I would say, I just want to throw out to the group, my impression is that in different parts of the world and in different centers located in the same parts of the world, that there are actually very different practices regarding the specifics of anti-infective management. And I just want to throw out to the group, for clinicians, is it you guys who usually take care of your ID issues, or do you have an infectious diseases person who is going to be making the management decisions on AML patients? For us, I can say that we do this collaboratively. We don't turn over the patients to ID, but we do have ID consultants. I'm seeing a lot of nodding in the group. Is there anyone in the group who fully turns over the infectious management away from hematology into the ID service? And how does that work if that's what you're doing? Okay, so nobody's doing that. So then the next question is the biggest area of controversy, I would say, for outpatient management in particular, the concomitant azoles with venetoclax, I think, gets a lot of discussion, because I think pretty much everybody for inpatient intensive induction is using neutropenic antibiotics as well as an antiviral and an antifungal. But the real question is the azoles and venetoclax. Would people agree that that is what's causing trouble for clinicians at the moment? So can somebody who does not use antifungal prophylaxis for the non-intensively treated patients jump on and discuss how it works for your center? So you have a newly diagnosed patient who's getting—
So we don't, Gail.
Regimen. Okay, go ahead.
So Gail, we do not. So our patients, particularly if they're being treated outpatient, our patients who are getting their first cycle and they're not secondary and they have not had prior AZA, this is de novo AML, who are getting AZA-Ven, do not receive azole prophylaxis.
Okay, and why do you make that decision?
Because there's a strong feeling in our group that decreasing the dose may not be as good as keeping the dose in that patient population, because none of the studies allowed for decreased doses up front in that patient population. And so our group does not do it in the patients up front unless they have unless it's not prophylactic.
Okay.
And we rarely run into problems with fungal infections. I cannot remember one where it hasn't been with a patient who's not had long-standing cytopenias because it's relapse disease or long-standing MDS beforehand with prior AZA, that we've not seen fungal infections in this patient population.
Okay, so Eduardo does the same. We do it differently. We prophylax everybody. Courtney, I think, had to leave, but I know MD Anderson does also, because we have discussed that recently. Agnieszka, I see your hand up.
Yeah, so we are selecting the patients for antifungal prophylaxis. So just particularly if we are using it, we are trying to use it at the first cycle. And if the patient achieves CR, we are continuing the treatment without antifungal prophylaxis to avoid the dose reductions and also suspected increased toxicity. But we have started also to use AZA-Ven for selected subset of patients without antifungal prophylaxis, because the rate of fungal infections observed in our population wasn't high. and only patients with complex karyotype with low probability to achieve CR, we are trying to select for posaconazole prophylaxis. So
And
it's
I'm going to have
approach.
one more comment from Andrew, because I saw your hand flash.
We're similar. I think we're moving more towards a risk assessment, and if the patient is not deemed to be, very high risk, then we're not using routine antifungal prophylaxis. In fact, we had a trial where we had a triplet, and we had to avoid giving azoles for the first cycle because we were unclear of the PK interactions of the third drug. We had over 100 patients, and there was maybe 2 fungal infections without any routine antifungal. We don't use routine antibacterial prophylaxis either. Only we give the patients oral antibiotics to take home and give them instructions to take that at the first fever. And we're trying to develop more enhanced monitoring of outpatients and looking more at the outpatient use of home pulse oximeters and measuring respiratory rate, because fast respiratory rate is a really early sign of sepsis. And we just don't find the gastrointestinal toxicity to be as high as intensive conventional to warrant it.
So I'm going to close that part of the discussion by saying I think it's super important that we all look and relook constantly to evaluate this. Obviously, I would be strongly in favor of as little medication as possible, because these drugs are expensive and toxic and nasty and interact and are difficult for patients to remember. So I definitely, I hope to be able to unwind our process to use less of it, but I still worry that people in different areas may have actually very different patterns of infection in their patients, and probably need to watch closely to make sure that the outcomes aren't adversely affected. I want to spend a minute on number 2, which is the coping with the diagnosis. And I think that everybody on this call happens to be a friend and a colleague, and I know to be a nice and kind doctor. And I think that we are probably generally nice people in helping our patients cope. But I wonder whether anybody would comment on the what can we recommend, or what's available, or what can we do that's even better, especially for the patients who are going to be facing prolonged hospitalizations for intensive chemo, possibly with restricted visitors due to COVID, et cetera. Is there anything that is a trick of the trade that somebody could say that we could or should be doing better for these patients to help them cope? Yeah, it's probably too hard a question, actually, as I'm guessing from the
so Gail, there's
silence.
there's an increasing literature and clinical trial work going on, actually really recognizing this. Patients have reported how they feel abducted, and they're kind of, now someone came and whisked them away. They had a normal life, and then suddenly overnight they don't, and it's gone, and they can never.
I think we lost her for a second, but I really do agree with the first part of what she was saying, that I think that there is an expanding literature and work trying to recognize how tough it is for patients to go through all of this and to, as she said, get whisked out of their normal life. And I do think that part of what we're doing here on the Hub with respect to disseminating information will hopefully be of help to them. I want to, in the last 60 seconds. Yeah, please jump in.
All right, Jeff, sorry. So just on that note, one aspect of coping that we've been looking at here, patients have recognized, is loss of continuity of care during treatment. I'm not sure how it is at other centers, but as a large tertiary center, we often admit patients to the hospital after the initial visit, after a long discussion, and then we don't see them again for 3 or 4 weeks, and they feel lost. They complain about the lack of continuity, the multiple different people taking care of them. Not as much of a problem on the outpatient, but that lack of continuity is definitely an issue when it comes to patients coping with the diagnosis after they've received it. So perhaps something to address as well in a larger forum.
I think that's a great point, Jeff. And I think that that is something where, depending on your center and how that structurally works, I think that is something that is a great point. And I could certainly see patients having a tough time with that. And maybe we can use the COVID era, things like FaceTime and calling patients more and having that, which didn't used to be such a feature, to sort of jump on FaceTime, even if you can't go into the hospital and say hi to people. There are different strategies that I think we could do better. And I think it's great that you brought that up. We have 60 seconds before all of us need to either go to sleep, depending on where you are in the world, or take care of patients. But the issue of diet and microbiome is actually, it's such a black box. And there are so many patients who are told that they can't eat anything from, sushi to salad to anything that might have interacted with a bug. And they go on weird neutropenic diets. And then they're at the same time told that their microbiome is being messed up by antibiotics. And then half the world wants to give them probiotics. And then the ID people go crazy because we're giving probiotics to neutropenic patients. Does anyone want to direct us quickly to something about diet and microbiome that we could actually point to educationally for patients? Does everybody make people follow a neutropenic diet who's getting AML therapy? So even there is inconsistency, I would say. There are data a long time ago from MD Anderson suggesting that the neutropenic diet wasn't helping anyone with AML. If you go, Jeff, into the hospital at your place, do the patients have to follow a neutropenic diet? Is there like a nutrition thing that they have to follow in the hospital?
Well, I think we do what a lot of places do. We have an in-house nutritional team that makes recommendations for high protein, high calorie. And there is a neutropenic diet that excludes certain types of, foods like uncooked meats and unwashed fruits and vegetables, but it's not highly restrictive in that sense. So we haven't really viewed that as much of a problem as just trying to get good nutrition into patients who are dealing with issues of mucositis and poor appetite.
So I think that's a great point to actually end on, that good nutrition and focusing on what you can get in rather than restrictions is probably a good thing. I don't think anyone is advocating raw meat, raw oysters, or raw eggs for any of our patients, but I do think it's worth mentioning, just since we're being recorded, that simple things, for example, like a probiotic or something that is definitely thought of by patients as, definitely healthy and harmless, is probably not either healthy or harmless. And I do think that supplements in general we should be very careful about assuming that supplements are great. And our nutrition teams are very careful about recommending, just because something is organic or natural doesn't mean it's safe for neutropenic patients. Things like unpasteurized honey or whatever can kill you. So I just think that all the things that are on the self-help websites that look like they must be good for you may not be good for these patients, and we should be careful about that. And I will give Uwe the final word of the conference with your hand up.
Please don't give me the final word. What I just want to make a link to the previous discussion. Something which really influences the microbiome is excessive use of antibiotics, including prophylaxis. And I think this could be a nice link to the previous discussion you may make here, that I think we need to be these kind of antibiotic prophylaxis needs to be chosen wisely, and also only intermittently, not like in the old days where everybody got ciprofloxacin for 3 months in a row. I think this has a significant impact on the microbiome and maybe also on the immune function, as it has been shown for also checkpoint inhibitors. This is not something used for AML, but I think you never know what is basically also influencing here. So just as a last comment.
That is actually a perfect last comment. I want to be mindful of everyone's schedule. Thank you very much. I hope to see everybody at conferences, and thank you very much for participating in this. Much appreciated.